The views expressed in this podcast are my own and those of my guests. They do not represent or reflect those of UCSF Health or my professional and clinical roles there. The content is intended for informational purposes only and is not medical advice. Please consult a qualified healthcare professional for specific medical guidance. Welcome back to In the Loop, the podcast that brings clarity, connection, and a little curiosity to the world of healthcare. I'm your host, Nadia Vlasiuk, nurse practitioner, educator, and your guide through the complex systems and simple moments that shape our experience of medicine. In today's episode, we're diving into the world of adult congenital heart disease, or ACHD, a field that's growing as more and more children with congenital heart defects are surviving and thriving into adulthood. But living with a heart that was structurally different from birth brings lifelong considerations, and not all adult cardiology teams are equipped to manage these unique patients. To help us understand this specialized area of care, I'm joined by Karina Manayan, nurse practitioner with the Adult Congenital Heart Disease Program at UCSF Health. Karina works at the intersection of two worlds, guiding patients as they transition from pediatric cardiology into adult specialty care, and helping them navigate everything from pregnancy to pacemakers with compassion and clinical precision. We'll talk about how congenital heart disease differs from acquired heart disease, what adult congenital patients need that's often overlooked, and why building lifelong care models matter. Not just for survival, but for quality of life. Karina, thank you so much for joining me today for this episode about adult congenital heart disease. Before we actually get into that, can you share a bit about your journey into nursing?
Yeah, thanks for having me on, first of all. I come from a family where there's a lot of people in medicine, so I always knew I wanted to do something in healthcare. I got my bachelor's degree at San Diego State in community health education. I really like to teach, and from there, I really felt like I actually wanted to be clinical. I figured out that nursing was my path. I always wanted to go to UCLA, so I did the bridge program there, bachelor's to master's. All the while I was working in their pediatric ICU, and we took overflow from the pediatric cardiac ICU, and then we eventually merged. And so I did, everybody loves their organ. So I always liked cardiology. And so when I had the chance to take care of cardiac patients, I did gravitate to them more. So that was my first experience with pediatrics and congenital heart defects. And then I moved home to Napa and I worked at Planned Parenthood a little bit. I do love the adolescent population and the young adult population. And you do quite a bit of education there too. So I did that for a little bit. And I don't know, once you are out of an academic institution, sometimes you figure out that you really belong back in an academic institution. So then I worked at UC Davis. I worked in their pulmonary rehab where I learned a lot about COPD, pulmonary fibrosis, pulmonary hypertension, and really using lifestyle changes and exercise to improve morbidity and mortality in this group. And then from there, we were talking earlier about missing the ICU, so I have to get back to the ICU. So then I took a job in pediatric CT surgery at UCSF at Mission Bay. They just opened the new hospital. They just brought on Mohan Reddy, who is a world-class pediatric heart surgeon. And it was definitely the highlight of my career was to be a pediatric cardiac surgery nurse practitioner, and especially the privilege of working with him and seeing the most complex hearts from all over the world being operated on and taking care of them in the ICU and in the step down. So that's where I kind of learned to love the congenital piece. When you consent the patients, then you really have to understand the heart defects and then what it takes to repair them.
Yeah, absolutely.
So that was a very intimate, very intense in just learning about the hearts and then taking care of the patients. And if you can imagine, they were operating from 6 a.m. to midnight sometimes, and it was just a job that could be 24 hours a day. My son was 4 years old at the time, and it was really difficult to work 80 hours a week and have a 4-year-old.
Wow.
So then I went to the ambulatory side of adult congenital heart disease. And then, I'll never forget some of the physician's assistants that had some experience in ACHD, for sure, adult congenital heart disease, said that it was their favorite population and that I'll never want to leave. And I did find that to be true. And especially my unique perspective in seeing from birth, really. I mean, I even went to the NICU. And took care of our patients there from birth until, 18, and then coming over to the adult side and really looking at the patient and looking at them and saying, oh my gosh, you made it. I'm getting chills right now just thinking about it. But really, there's always a point in the time when you're looking at the child in bed with all the lines and the drips and the meds and all the vitals going on, and just kind of looking at them and saying, are we doing the right thing? And then when they start to live longer and have a good quality of life and they make it and they're, 44 years old and they have kids, and you're like, okay, well, that was worth it. You just go home and you're with your stomach in knots sometimes when you're leaving the bedside and the kid has an open chest and you're like, what are we doing? We're, being able to do full circle has been a definite privilege. And
that path is just amazing.
Super lucky. And then, of course, I got an opportunity to be a supervisor position, and then I went to that. But it's actually, I love ACHD, but also advancing nursing and nurse practitioner or the advanced practice providers in cardiology is definitely something else that I have a passion for.
Yeah. So I actually benefit from that. So thank you, because you are my supervisor. But since we had no supervisor, and now that we have you, you're such a strong advocate for us. And I love that you mentioned that, because that's a piece of nursing that I think doesn't really get out. It's like we have that clinical piece, but then we also take care of each other.
Yeah.
And so you are definitely a nurse's nurse.
Well, thank you.
Thank you. And that's one of the things about nursing that's amazing. I was a house supervisor at one point in my career, and I loved being a nurse's nurse. They call you and they're like, I need a little help here. And you get to go in and help that. So.
Yeah. And patient care is one thing. And then colleague care is what makes it a perfect kind of union and, for your career. And I just like the idea of just having each other's backs, because I know, we only have each other. I love that line. It's from my favorite movie, one of my favorite Christmas movies. But, it's a super dysfunctional family. It's The Family Stone.
Okay. I actually only just watched it this last holidays.
I don't miss it. But there's one point where the mother is just like, we only have each other, and it's so true, we only have each other's backs. So, but we're all
caring for patients, and we all want to do better by them. And then by supporting each other, we're helping each other with our patients.
Yeah.
So it's beautiful.
Yeah, I think so too.
Absolutely. So your role has changed a little bit, because you went from being a clinician to now supervising. Do you get to do both pieces?
I do. Luckily, I created the transition education program for our ACHD program. So I don't think I ever want to let that go, but I might have to at some point.
Practice. So thank you so much for sharing that and your path into nursing and into ACHD. Can you explain to us about what adult congenital heart disease is and all that entails?
So adult congenital heart disease is just kind of like electrophysiology. So it's the general disease state. And then the congenital heart defects are, the heart anatomy abnormalities that they were born with to make up what they have. For instance, like Tetralogy of Fallot or ventricular septal defect. So those are the defects that's the more specific term, but the general term for it is adult congenital heart disease.
Okay. So many people think that congenital heart defects, that's just a pediatric issue. And clearly it's not, as you've already demonstrated, but why is it important to focus on adults with congenital heart disease?
So it's a very fast growing population just through research and scientific and medical advancements. Over 60 is the fastest growing population for congenital heart disease patients, which is really amazing. They're living longer, whereas, they didn't really think that you were going to live into adulthood. And even our most complex patients, the single ventricles, are living into their 40s, and having good quality of life. It's a population that's just growing bigger and bigger every year.
When patients were born with these defects, where in the timeline did they start to live longer into adulthood? Because I'm sure that a lot died before there were even treatments available, but how did that kind of timeline?
Yeah, cardiopulmonary bypass.
Okay.
Because you have to stop the heart. So the heart and lungs have to still function. So that was a really big pivot and growth point is when that got developed in the 1950s, 1960s, somewhere around there. Because, you have to arrest the heart to deliver the cardioplegia, arrest the heart and be able to fix it, repair it. So that was a big change.
Wow. That's amazing. So what are the most common congenital heart defects that you see in your practice?
UCSF is, there's just a few ACHD centers, so us and Stanford. I know UC Davis. They take care of ACHD patients at Kaiser. They don't do the surgeries there, I don't believe. So we see everything. The most common ACHD defect is Tetralogy of Fallot, but we see everything from the simple hole in between the upper chambers, which is called atrial septal defect, all the way up to a single ventricle. The two bottom chambers, one of them isn't developed fully, and so we call them single ventricles, which would be the sickest or the most complex, and then everything in between. We see it all.
Can you explain Tetralogy of Fallot?
Yeah, so Tetralogy, Fallot is the French physician that found through autopsies of blue babies. So he would look at their hearts and he realized that they had 4 things wrong with them. So the VSD, so the hole in between the bottom chambers, an overriding aorta, a thickened right ventricle, and then the infundibulum. Pulmonary valve was stenosed, but then the area underneath the pulmonary valve and that whole pathway is narrowed.
What does stenosed mean?
Just kind of thickened and hard and narrowed.
Okay. And what symptoms would a child have if they had Tetralogy of Fallot?
They would turn blue. When your heart returns, when the blood returns to your heart, it needs to go to the lungs to pick up oxygen and return back to the heart and get pumped out to the body. So when you don't have that pathway or the pathway is hindered from the narrowing, then you don't get enough oxygen to all your tissues and you turn blue.
Okay. So for these congenital heart defects that patients have, how late in life can they be diagnosed? Is it usually really quick, like soon after birth you find out, or could they be like in school?
I mean, yes. The answer is yes. So you typically get a fetal echocardiogram at 20 weeks of gestation, so that you can find out that early.
Wow.
Just depending what it is. And I know our practice is wild. We see, we can see somebody who has had coarctation of the aorta, which is a narrowing of the aorta, show up at 32 years old, has been playing soccer his whole life, and all of a sudden, has high blood pressure and like his legs feel super heavy and has had this defect his whole life.
Wow.
Yeah. So, or we get something like a partial anomalous pulmonary venous return. I mean, I feel like you can live with that and we not find it into your 50s, so there's just certain ones. Maybe a patent Forame and Ovale as well.
Yeah, I see that all the time.
I mean, it's almost like not normal. It's almost normal. Sometimes it's just like a normal fetal circulation. It just hasn't closed and then also hasn't caused any real changes that the person has felt. But normally something like Tetralogy of Fallot, you would know right away because the baby would be struggling.
Going back to the patent Forame and Ovale, can you explain what that is?
Yes, it's part of the fetal circulation and it's a hole in between your upper 2 chambers that's called the atria. And typically when you're born, pressures change.
As you're
and then
gonna breathe.
Yeah, because then you start breathing air into your lungs, and then it would normally closes. It depends on really if it's going to cause problems. It depends really how big it is. Okay. And then what we call hemodynamic issues, where if the blood flow not going in the correct direction kind of returns and mixes, and it just kind of wreaks havoc.
Now,
and then you have it.
Is that an atrial septal defect, or are they two different things?
They're two different things. Just they look different. They're kind of like formed differently.
Okay, great. And like you said, people can have those and not know it forever.
Yeah,
probably.
You can have an atrial septal defect too. That's kind of small. But if anybody's listened to a heart, you can kind of hear. You'll hear a rush sometimes, and some people will catch it. Other people would think like, oh, it's an innocent murmur, or, so, I mean, it just depends. A lot of the times if it's not causing any problems, you can leave it open, so. Yeah.
Okay. Yeah. How has the care for ACHD patients evolved over the years?
So now we have an accreditation that you can get, and you get it through the Adult Congenital Heart Association. And they've really, they really looked at every area and make sure that anybody with this accreditation has the adult congenital heart surgeon, which we have, who also does transplants, making sure that we have the physicians that are credentialed and specialize in adult congenital heart disease. Then you have your nurse practitioner or APP support. You have your nurse support, social work. There's a big mental health, behavioral health component. And I think that comes in general with patients that have chronic diseases. And then a program coordinator, patient care navigators, and patient care coordinators that all support organizing their care. In addition, we have radiologists that specialize in, you can't get a congenital MRI at your community hospital. You definitely have to come to UCSF for that. Congenital CT, so our radiologists really have to be specialized as well. And then all of our partnerships, so hepatology, making sure that with our single ventricles, or we refer to them as Fontans, because of the final surgery that they get, they often have a lot of liver congestion. So making sure that we have hepatology on board and partnered. We also have cardiac dietitians that we lean on, pharmacy technicians that we lean on, and then let me think, we also have cardiac rehab. So it's just really a center that looks at the whole patient.
That's great. So it's a big multidisciplinary
it's
venture.
That I'm missing. I know I'm missing somebody, but it's a multidisciplinary venture for sure.
I want to go back to something that you said about like the mental health and like emotional support, because the patients that you see in the adult clinic are patients who have been managing care for, like you said, a chronic disease, a chronic cardiac issue for probably almost their whole life.
Yeah.
How do you see the support for that, and how do you help support that?
Oh, geez, I wish I had $1 billion to support that. So, the fetal circulation isn't normal, right? Since it starts from in utero. We're doing a lot of research. We just had a fantastic pediatric heart center research conference on Thursday, and there's just a lot of really great neurocognitive research that's being done. But when I just kind of even looking at from day one that they may live in the hospital for a while, and just being in, just everything, just from the rooms being poked and prodded, having the echoes done, the EKGs done. I mean, going in and out of the hospitals multiple times, needing to see your pediatric cardiologist multiple times a year from the start of life. And then it does something. It has to, right? Yeah. So I think our patients have a lot of, not only are they sometimes cause genetics, through like it's either DiGeorge syndrome, or, they have neurocognitive deficits, or they're just simply maybe traumatized from multiple hospitalizations, throughout the course of their lives. It shapes someone.
Imagine they have a lot of grief too, because their childhood looks different than a lot of people around them.
Yeah. Yeah, a long time ago, they weren't allowed to play all the sports. They weren't allowed to, the parents were very protective.
Absolutely.
And So, some people are able to come away. I don't want to even speak for them, but just like seem a little bit more like they've coped better. But I don't know that that's the majority. That's definitely not the norm.
I'm sure support and understanding and help through all of it probably helps those.
Yeah.
But I imagine it's got to be tough. And are there specific, I don't know, counselors or therapists that work with adult congenital heart patients?
Well, in pediatrics, when they're in the pediatric hospital, they'll have multiple social workers. Ronald McDonald House houses the parents. The parents can sleep at the bedside. There's child life that helps with developmental milestones, and they also help with procedures and kind of teaching them like about IVs, teaching about the MRIs that they're going to get. So I think in pediatrics, they do a pretty good job, and we actually just saw a really nice presentation by Lori Feynman that they're doing even more at the bedside to help with developmental milestones in the ICU. So in pediatrics, I think they do a lot. I think in adults, it just gets hard. When your parents are in control, and even if your parents weren't in control, we could call CPS and make somebody in control, and to take care of the child. But the truth is, when you're an adult, it's up to you. And when you're 21, you just kind of want to be 21. You're going into college, or you're just at your first job, or you're transitioning in so many different ways. And the last transition you want to do is from pediatric cardiology to adult cardiology. And a lot of them are so super challenged and suffer. There are a lot of resources for mental health and behavioral health. I think they're harder to obtain and to maintain. I think we have a wonderful social worker, and our social work department has really great resource people. But again, it's just a lot of our patients are on Medi-Cal, and it's just the systems is just taxed. Like behavioral health and mental health is just completely taxed. I think we do the best that we can. I don't think anybody stays in adult congenital if that's not their people.
Right. Yeah.
And that you don't have this like unending well of compassion for them. So you just, listen a lot, you acknowledge how they're feeling. Even if I don't have the resources for them, you just sit on the phone. I don't know. You meet with them as much as they want to or need it. But right now, our social worker is really looking into support groups. So I think that's going to be an important piece for our patients.
Absolutely. You kind of touched on some of the challenges that these patients face as they transition from pediatric to adult care, but are there any others aside from like they just want to be 21 and not worry about
the transitions? I think it's really hard because you grow up. A lot of our patients have California Children's Services, which is the Medi-Cal for kids, and then you have to transition to Medi-Cal. Not a lot of our patients have resources where they can just enter mainstream and and go to. They can go to a 4-year college, but a lot of them are walking the line between like making too much so they can still have Medi-Cal, and then the ones that do go to the 4-year college, then I'm having the conversation when I do the transition visits to say, make sure that you have benefits. Because you're going to get an echo every year. You're going to get an EKG every year. Make sure that your deductible isn't $5,000 because you'll be paying $5,000 every single year. So it's a lot. It's like totally overwhelming for them. When you're in your 20s, you're like barely using it.
Right.
You're barely using any of your insurance. But for them, it's opposite. They're going to be using all of it. So I think resources and insurance and access, I think those are really big issues coming over as well.
So when they're pediatric patients, at what age do they transition into adult? Is it 18? Is it 21? Is it dependent on their parents' insurance or Medi-Cal? How does that work?
So in the pediatric world, they start talking and educating about transition at 14 years old. Okay. And then every 2 years, they go through the readiness assessment. I've partnered with our pediatric nurse practitioner who's doing transition. We essentially created a program together where we have just like all the same information. Okay. So they can come over at 18. We have a chronic disease wellness management department now at UCSF that is is creating a huge department and pathway for all children that have chronic illnesses. And so they have a pathway to the adult world. They've done a ton of work, and they are extending it until 26 years old. So you can stay in pediatrics until 26, and then after that you transition.
Okay.
So that's the one question. A lot of pediatric physicians are like, you can go at 18 or you can transition at 21. Some are like, when you're pregnant, you're moving. But, you know, it just, a lot of pediatric cardiologists are just accustomed to taking care of adults because they didn't live to adulthood for so long. You know, they had a precious few, but now that's changed. So the other piece that you said is that a lot of insurances will cover your young adults until they're 26. So they don't have to come over until then.
So you do have more time to transition, but it's great that you're starting at 14 to try to, you know, assess that readiness.
Yeah. I mean, it's also difficult. The elephant in the room is the pediatric cardiologist is the one that saved your life, right?
Yes.
And the bond is strong, and, you know, they do such a great job. But also the parents. Imagine spending 18 years of your life with this person in this really precious partnership, and then saying, okay, you go now. And then like landing in a place where it's just like, it's up to you what you do. You know, it's just kind of difficult. So the parents don't want to leave this pediatric cardiologist. The children don't often want to leave. And then, so that is a big challenge too.
Yeah.
And the pediatric cardiologists are like, those are my babies. You know, I can't.
Exactly.
I think it's hard.
Yeah. I mean, at least they get to come to you and your team, which I know are all great, loving people. But as a patient, you establish this relationship with someone that you trust. And then you're like, wait, I can't stay with you anymore. Wait, and now I have to go to some stranger that I don't know and doesn't know me. And like, oh, that's scary.
Yeah. You have to grow up. You have to drive. You have to get a car. You have to go to college. You have to go to that. It's like all these things. And they're like, oh my goodness, can we not do this right now? Yeah. So I think that in general is the big piece.
Yeah, absolutely. So how do you approach long-term management and surveillance with these patients?
Well, in the beginning, you just have to create a rapport, just stay in touch and connect with them in every visit, and then gain that trust. And our nurse does a really good job at being friendly and being accommodating and being there for them and listening, coming off the heels of pediatric cardiologists and, you know, really gaining their trust, I think. Because most of them need to be seen once a year with an echocardiogram and an EKG. Some can go 2 years, some can go 3, some can go 5, but that's not a normal maintenance schedule. Just making sure that they stay in care, they understand how important that is. You know, and that we call them and let them know. Remind them. We usually say, like, it's not a great way to celebrate your birthday, but around your birthday, that is your annual thing, you know, so you don't forget, when was the last time I had my echo? Oh, it's always in September. Yeah. So those are like some of the tricks that we help them with. We've also created an app. You know, young adults very much so, you know, use digital health media to do everything, and we all do. But especially, it's really like they're managing, it gives them education, it gives them guidance, gives them support, and it's at their fingertips. It's also available for lower income and different populations. So being able to have this app that supports transition as well, I think is important for the wider audience.
Yeah, it gives everyone access, which is great. What role does pregnancy and family planning play in ACHD care?
We could probably get almost everybody through at least one pregnancy, you know, even the most complex, the Fontans. We do preconception counseling. We make sure we talk to them about if there's a genetic component, what their risk is to the offspring. And we would like for it to be planned, and then make sure in that planning there's the echocardiogram, the 100,000-mile checks, the exercise test, the echo, the EKG, the heart monitor, and make sure they're tuned up and are safe and healthy enough to undergo the pregnancy. We also have a pregnancy and cardiac treatment center. We have the most wonderful high-risk obstetricians that we partner with. A lot of our patients are safe enough to have their babies in outside hospitals. So we also partner with them in arranging that. It's actually the possibility whereas like 15 years ago, maybe even 15 years ago is not that long. I mean, before the 2000s, maybe they were being counseled that they couldn't. I think there's been a big change.
It's amazing because we go from, children not making it many years to now they're making it lots of years, and now they can have families.
Yeah.
And now like you can, through care from providers such as yourself and your colleagues, you can give people this life extension and a good quality of life, which is amazing. Yeah. I know we had talked a little bit about multidisciplinary care a little bit ago, but I kind of wanted to back up to that as far as because I know at UCSF, we, like the tertiary quaternary centers, like everybody gets sent to us that no one else can fix or, because we have the expertise. And how do you manage the ACHD patients that are say somewhere in the Valley, or 4 or 5 or 6 hours away? Do you collaborate pretty closely with the providers that are local that don't really have the experience in it?
Absolutely. So, number one, they have to have a primary care physicians. And, the primary care physicians in the outer reaches of California are really great because they have to be. And then we partner with their general cardiologist. So somebody boots on the ground type thing that can listen to their heart. They know what it looks like. They can get an EKG. So somebody nearby. And then we collaborate with them. And they come into UCSF for their specialty testing at least once a year typically, and then they'll have somebody that they can rely on locally.
Yeah, that makes perfect sense. Working with more rural providers and things that are closer to these patients, because not everyone can live in San Francisco or even be close to the Bay Area. There'd be too many people. Right. How can healthcare professionals better support this patient population?
Well, I think a big issue that we're having at UCSF is approaching 50% of patients that have an ACHD do not see ACHD providers. Wow. So it's really important that they are cared for by ACHD providers. I think that's it. Making sure that you are in specialty care is the important thing. So
if you're a nurse that's listening, or you're an APP or another provider in another specialty, if you see a patient that has adult congenital heart disease and they're not seeing a specialist at least once a year or whatever timeline or at all, they need to get plugged in with someone. So please send that referral.
Yes. I've seen multiple patients come through who are seeing a cardiologist just in the peninsula who could have been cared for better and suffering from it. You just kind of wish that they would have come to us sooner.
Just being a subspecialist, you know exactly what is going on with their heart, and you know the things that can be done and how to manage it well. And sometimes it doesn't need your expertise on it all the time. But if something's going wrong or awry and they're getting the treatment of someone that's just typical heart, that may not be the best treatment for them.
Yeah. And we have a case conference every Friday. That's so well done. It's my favorite time of the week, where we have all the specialists in one room or Zoom. And we invite everybody from the outside to come in and present their patients too. So you can manage the patient on the outside, but then come and present them second opinions, or we want the surgery to be done at UCSF, and then we'll all collaborate. It's a really nice conference, but we do welcome people from
the community. Yep. Yeah, that's awesome. What lifestyle recommendations do you give to your patients in terms of exercise, diet, daily activities, or does it really depend on the defect?
Yeah, I think, it's so generic, but the American Heart Association is 30 minutes, 5 days a week, or 150 minutes, however you want to do it. But then I looked at myself and I'm like, am I doing that?
Right.
And it takes a long time. And I'm like, so I have a dog and I have to walk her for 30 minutes every day because I need to do what I'm telling my patients to do. It is hard to fit in. And I do spend the time talking to them about light weights and cardio. Yeah. It is just so incredibly important. Being obese or overweight is just such an epidemic. So it's just really difficult. And I realize that. And we do have help, right? We have a cardiac dietitian. We have a weight management clinic. We have a lot of new drugs out on the market that we can prescribe for them. It's just really, really hard. But I do very much just get out there and walk, especially if they're about to go into surgery. Don't walk less. Make sure you're getting your daily walks. I know you're huffing and puffing because you need a new pulmonary valve, but get out there and move so you'll be better through your surgery. Especially with us and with adults, we have guidelines, we have parameters. We know just about when the valve needs to be replaced, but we do rely on the patient's subjective, their symptoms.
Yeah.
So you won't be able to know that unless you have a normal exercise regimen that you're seeing changes, because you can't it's hard to see it in yourself unless you always go for a 2-mile walk. And now the 2-mile walk, you have to stop in the middle, or you have to take a nap afterwards, or it's taking you 15 minutes longer. It's those kinds of differences that you're going to be able to tell us, I can't do something. I think it's now. So you kind of have to know yourself in that way. And that's kind of the most important piece for us too, is them knowing their body and being able to tell us about it when there's been a change.
What is one thing that you wish more people understood about living with ACHD?
Well, we still have a lot of adults who were told that they couldn't get piercings, or they couldn't get tattoos, or they couldn't play contact sports, or they couldn't do many things. But now you can do all those things. Yes, it's difficult. Maybe not football, but I think a long time ago, you didn't want them to run track. You didn't want them to overexert themselves. But I think we're kind of giving them more support in that you can live a healthier life and more normal life in that respect. Not that tattoos and piercings are it, but I'm of course you can go get a tattoo.
If that's what you like and it makes you feel good and also normal. Not that there's anything wrong with being special, but sometimes you just want to to have the experiences that everyone else can have.
Right. You can scuba dive. We just want you to tell us that you're doing it. You can't ice hike with a blood thinner. You cannot do that. Which I was can you wear 10 helmets? Which somebody asked me. And I'm please, no. That's a no.
Do you know how many questions we get about AFib in diving and things like that? And I work with Dr. Henry Shaw, and he's a medical diving officer. Yeah. So he knows all the
Did not know that.
Atmospheric pressures and things. So he gets a lot of questions like that. It's very interesting.
So can you dive with AFib?
Yeah.
Yeah. I don't think so. Why wouldn't you?
Yeah. I think it's more some devices you can't dive with. They're not, you can't really seriously dive, but you could snorkel. I know I probably just offended everyone in the scuba diving community, but it's I'd have to do some more homework on it because we don't get it that often. But there's the limitations are so small now. Where I think before you couldn't do anything. People didn't think they could use a microwave with having a pacemaker.
Right. Yep, all of that. Through research, we know more now.
Evidence shows us.
Evidence-based.
So I know that you helped create the app for that transition program. Are there any recent advancement in ACHD treatment or care of patients that are exciting to you right now?
Everything. So Dr. Anushree Agarwal created the app through her research, and I helped with content because I was doing the transition program. So I want to give her a little shout out. She's worked so hard and she does such great research, and we're one of the little projects that she was doing, and she's doing 5 more. She's doing a ton of research. So
that's amazing.
Really wonderful. So I think advancements, everything from better heart failure management, better pH management, better surgical techniques, 3D printing. Our imaging is fantastic. The CTs or the MRIs. But now with the 3D printing, when you're just where does that lead to? They can do the 3D printing, they can do the model, and you can actually stick your pen and say, this is the way that it travels. And then that gives the surgeon a better idea of the repair that they're going to do. We have a brand new ACHD interventional physician coming on. When you've had open heart surgery 3 times, you have a significant amount of scar tissue. You opening it up for that 4th time is not going to be the surgeon's favorite thing to do that day. The interventional catheter-based procedures have been life-changing, life-extending for these patients. So doing everything from putting in a valve, extending their lives that way, putting in stents, coiling, doing Wardens. I think it's repairing partial anomalous pulmonary valve, Retrun. They're doing amazing things like putting in devices to close atrial septal defects. It's just amazing that you don't even have to have open heart surgery for that and you're going through their leg. It's absolutely a game changer for us. You have to really understand the congenital heart defect to be able to go in there and put the valve in the correct space. But, you just have to really understand the anatomy and physiology to be able to do these valves and devices and
Yeah, because when you're
coiling you're like, where am I? Exactly. It's not the same.
It's amazing. Yeah. How can listeners connect with resources or learn more about adult congenital heart disease?
So the Adult Congenital Heart Association is a website for providers and patients, and it's wonderful. There's more than 10 years of monthly webinars by experts and ACHD from all over the country for patients and families. There's lots of educational material on there. You can find doctors in every state that specialize in ACHD, also internationally. There's just a lot of resources on there for patients in general. And then our app is called Empower My CH. It stands for Empower My Congenital Heart. You can find that online and download the app and start to use it to help you, get education. And what I really love about this app is that we created it with congenital patients. And they had a ton of input. There's a lot of peer advice. There's an expert advice and everything from like, what do you do before your CT or what do you do before your MRI? Should you hold your meds? Who do you call? Like tons of real life situations where you're just like, where do I start? So this app is really wonderful for that. So Empower My CH is so helpful for that. And then of course, UCSF ACHD, Adult Congenital Heart Disease website. But, I feel like we're such a big team. We always partner. Everybody in this community knows each other, So I know that CHOP, Philadelphia, has a great website. I often use the John Hopkins website. It's pted.org. They have like every anomaly on there. It's a fantastic website. Yeah, we're a small community and all the information is shared and everyone's trying to do their best to advance it and really help and empower and educate patients. So there's a lot of really good websites out there.
That's great. I will post all of that in the show notes on Substack because it will really be helpful. About for nurses that are interested in working with either pediatric congenital hearts or adult congenital hearts or APPs that might be interested in this, what would be your recommendation on how to do that?
Well,
aside from just saying, hey, I want to apply for this job.
You mean just kind of how do they educate themselves? Or
or is there something that, I mean, you kind of talked about your like pathway into it, like say somebody's listening and right now they're like on a med surg floor taking care of post-op hips and knees. And they're like, this is really fascinating to me. I'd love to help people like this.
For me, I'm just the kind of student that wants to know from the bottom. Like I have to know what their heart looks like. I almost obsess about it. And if you've ever read one of my notes, I have like every year or like every surgery they've ever had, all the interventions that they have that are, that there was important findings. And I'll list it by year from the top. And it's because I have to have that in my head.
Yes.
That course in my head. So I think a really great place to start is that John Hopkins website, the pted.org, and just really looking at all the different heart defects. And see if it fascinates you.
Okay.
And just learning from there. Because obviously, if you have Tetralogy Fallot, then I already know what their course looked like. And very seldom does it look different. But then when it does, I'm like, whoa, what happened there? And then it's like, oh, this is why, So I'm just like, I have to know every milestone that was in there. Yeah, I don't know. I think also too, getting into adult, you do a lot of heart failure. Okay. You do a lot of pulmonary hypertension. Our most complex patients also, if they choose to, go to heart transplant. One thing I didn't realize realized when I started is that some of the patients are really sick in their 40s. And I was in my 40s and I'm like, oh my goodness, they're my age. And they're like super sick. So that was really tough for me because a lot of them, that was just kind of going to be really tough years from there on out. Obviously, there's a ton doing really great. But then the ones that are struggling in their 40, that was just kind of hard for me to be the same age. And maybe they were at the end of their battle with it or their life with it. So that was kind of hard to understand. Just a lot of patience, a lot of compassion, a lot of empathy, and just really understanding. We were sitting in an interview the other day, and I asked the person, I'm like, what's your favorite heart defect? Because I'm such a nerd. But because everybody has one that they like, and there's the most interesting one to them. But, this population has to resonate with you.
So what's your favorite heart defect?
Well, I mean, I like them all. No. I think Ebstein's is really cool. Really? I think congenitally corrected transposition of the great arteries are really cool. I mean, we also have patients that have hearts that you're like, what is going on? And they don't think it's that interesting. But like for me, I'm just like, what does this look like? And at the end of the day, what we try to achieve is like, what's the best physiology for this patient so they can lead the most healthy life that they can with their current configuration. So I don't know. I feel like the most challenging hearts, they're my favorite, when you're trying to figure out what connects to what.
Yeah, that's amazing. I mean, but I don't think it's nerdy because I've had many a conversation with colleagues and been like, what's your favorite valve? I think that's just us in cardiology.
I think it's just us. I don't think people. I think someone's going to turn the podcast off right now. They're like, this is too much.
But, when you get into subspecialty, you're really diving in. Like,
you're not here because you just,
You're like, wow.
Yeah.
I really love all of these electrical rhythms. I do, though. And most people are like, what? Like,
we like that you like them because I know why. I will send you every single EKG.
I know. We had another colleague over today and we were all sitting around talking before we recorded this episode and like, oh, do you have an EKG book? I was like, wait, just a second. And I walked down with my arms full of books. I'm like, I like all of these.
These are all my favorite. They're all bookmarked and dog-eared.
Exactly. Well, Karina, thank you so much for coming on and talking to us about adult congenital heart disease. It's been a pleasure. Thank you.
Thank you so much. I think you can tell, I just really love this population, and to get to talk about it to somebody who's also a subspecialty cardiac nurse, we're just kind of sharing our passions, and it's fun. It's it makes for like a great afternoon. So thank you.
Of course, my pleasure. And who knows, maybe in the future we can dive into one or two of the defects and, have another podcast on it.
Okay. Cool. Sounds great. Thank you.
Thanks for tuning in to this episode of In the Loop with Nadia Vlasiuk. I hope you found today's discussion insightful and empowering. Feel like diving deeper into the topics presented today? Be sure to check out the show notes for references and more helpful information. You can also visit our Substack or Instagram, Facebook, and TikTok. Remember to stay curious and stay informed. Now you're in the loop.